Hi, my name's Dr. Claire Treyers. I'm a paediatric pathologist and service lead for paediatric pathology here at Addenbrooke's, and I'm here with Amy White, one of our senior biomedical scientists, and our presentation today is to talk a little bit about the background to the paediatric pathology postmortem service here at Addenbrooke's and to go through the process of taking consent for a paediatric postmortem.
Hi, I'm Amy White. I'm the Senior Biomedical Scientist in the Paediatric Mortuary, and I'm going to go through the Paediatric Hospital Consent Form. So the first part of the consent form is a checklist, which is used by the delivery unit to make sure that all samples have been taken and sent to the relevant labs, and all pages of the consent form have been completed, including the clinical details form. A copy of this should come with the baby and the rest of the paperwork so we can double check that everything has been completed. The first page of the consent form is the covering page, which just has the addressographs of mum and baby placed on that front sheet. Page 2 of the consent form has the patient details of mum and baby. This should always be completed in full. There must be 3 points of ID that match between this page of the consent form and the ID band. So that would be mum's full name, mum's date of birth, mum's hospital number, mum's NHS number, or the same for the baby. If the baby is a neonatal death, the ID band must be in baby's details, and those details must be on page 2 of the consent form. If there are any religious requirements, this should be recorded on the consent form. The changing your mind section at the bottom of the page is a time for mum and dad to be given for them to change their mind about the post-mortem. We would typically suggest 24 to 48 hours for this time. The name of the person or member of staff must be recorded in this section with a full telephone number, including area code, and a date and time after which we will carry out the post-mortem. It must be a direct telephone number. It cannot be a bleep number or an extension number. Page 3 of the consent form details what post-mortem or what type of post-mortem we're consented to carry out. On this page, the consent taker should put a yes in the box for which type of post-mortem is consented to. So it would either be yes to the full post-mortem, or yes to the limited post-mortem, or yes to the external post-mortem. If the yes to the limited post-mortem has been completed, there are then further boxes which consent to what areas of the body we are consented to examine. Only 2 out of these 3 boxes should be completed with a yes. If all 3 have been completed with a yes, then that technically would fall under a full post-mortem. So we would have to clarify with the consent taker what exactly the family did not want us to examine. If anything is ever wanted to be recorded in that other section on this page, we would always request that a phone call is made to our department so that the case can be discussed with one of our pathologists, as sometimes this is where requests are consented to that we actually aren't able to carry out, such as MRI only PMs. Page 4 of the consent form details the consent for tissue samples. So these are the histology blocks and histology slides that are generated from the post-mortem histology samples. If the family consent for us to keep those as part of the medical record, then yes should be written in section 2. If the family do not consent for those blocks and slides to be kept, then the disposal option must be written in the notes section below this. The disposal options are return to undertaker or hospital disposal. Both of those will happen at a much later date. Our tissue coordinator will collect together the blocks and slides, typically 6 to 8 weeks after the PM report has been signed out. Section 3 is for genetic testing. So the family consent to genetic testing being done, in which case they would put yes in that first box, and whether we can keep those genetic samples as part of the medical record. So they would put yes or no in that second box. If the family don't consent for us to keep the genetic sample, it will automatically be disposed of by the hospital once testing has been completed. Section 4 is consent for the uses of those histology blocks and slides that we've taken from post-mortem, and the family consent to quality assurance and audit, for training and for research. And we require either a yes or no in each of those 3 boxes to show what consent has been given. Page 5 of the consent form is the signature page. So section 5 at the top, the family can ask the consent taker to put any particular requests or concerns. This can be left blank if there aren't any. Section 6 is for the parental consent section, so there should be a yes in all 3 of those boxes, and then mum must put her full name, sign, date and time, and the father can also do the same. We must have mum's full name, signature, date and time as a minimum in this section. In section 7, yes, this should be recorded in each of those 5 boxes. That's confirming that everything has been explained to mum and dad by the consent taker and everything has been fully understood. The consent taker should then put their full details in section 7, including contact number, signing date and time. If an interpreter is used, this section must be completed with the person that was used's full details so that we can get hold of them if there are any issues with the consent form. There are some brief notes on the last page of the consent form for each section and what is required. We also request the clinical details form to be completed in full and sent with the consent form. We appreciate that there are notes and scans on Epic, but we still need a summary of all events relating to the pregnancy, and that should be completed on the front and the back of this form. If genetics have been taken, they should also be recorded in section 6. Notes we can obtain from Epic. However, we will always look for the notes for these cases, for late stillbirths, for neonatal deaths, intrapartum deaths, and termination of pregnancy. We'll also need to be able to see the scans for all terminations of pregnancy. For neonatal deaths, we must receive a copy of the medical cause of death certificate and have it recorded in the notes that the case has been referred to the ME or the coroner and they are not interested in the case. That allows us to then carry out a hospital consented postmortem. The ID band, as I mentioned earlier, must be in baby's details if it's a neonatal death, and if the baby hasn't breathed, it must be in mum's details. Genetic sampling should be taken from a fresh placenta and sent directly to the genetics lab. It should not come down to the mortuary with the baby or the paperwork. The placenta should then be sent down to us fresh so that we can take further samples if required. This is a property form that we complete in the mortuary, so this is something that you won't see on delivery unit, but it's just to show that we track the property at every stage whilst the baby is in our care, and every time they are taken out of the fridge for the postmortem or for Woodland Suite appointments, we check the property to make sure everything stays with the baby at all times. If you have any questions regarding the postmortem service, please contact our team on the number here.
Addenbrooke's Hospital provides a regional postmortem service for the East of England, including Addenbrooke's and 12 peripheral hospitals. We perform in the region of 300 perinatal postmortems a year, along with hospital postmortems on older children and coronial postmortems. The service is provided by 3 consultants supported by a team of specialist biomedical scientists, mortuary staff and admin support. We have dedicated paediatric mortuary facilities at Addenbrooke's located in level 1 of the lab block underneath ED. Perinatal mortality in the UK has been on the decrease over recent years. However, according to the most recent Embrace UK report, the perinatal mortality rate still stands at just under 5 deaths per 1,000 births in the UK. Of these, just over half of stillborn babies had a post-mortem examination and around a third of neonatal deaths. Access to perinatal post-mortem services is outlined in the recent NHS policy statement published in October 2022, which is freely available online. This document outlines who should be offered post-mortem examination following a fetal or early neonatal loss. Details of the criteria can be seen here. However, broadly speaking, post-mortem examination should be offered in all cases of a loss over 12 weeks gestation, unless there is an already definitively defined diagnosis, and this includes known aneuploidy or in cases of clinically confirmed placental abruption. Confirmation of sex is no longer an indication, nor are cases for genetic sampling only accepted. If you have a case where you're unsure if these criteria have been met, then please contact one of the paediatric pathology consultants who will be happy to discuss any individual cases. Included in the NHS policy document is an appendix which gives an indication as to which investigations may be carried out in different clinical scenarios. This might be helpful when speaking to families. This, of course, is done within the limits of consent provided by the family, and the decision about the most appropriate investigations is made by the consultant pathologist undertaking that case, following review of all of the provided clinical information and taking into consideration the condition of the baby on arrival with us in the mortuary. So what is the purpose of a post-mortem examination? The first and most obvious reason a family would request a post-mortem is that they want to understand more about why their baby has died. The second reason is that post-mortem examinations may find information about conditions which can recur in future pregnancies, which may alter the management. Research has shown that post-mortem examination changes the clinical diagnosis in cases of stillbirth in around a third of cases. There's a significant change in the cause of death in 28% of neonatal deaths, and additional information about the cause of death is found in 70%. By contrast, examination of the placenta alone only identified a cause of death in around 20% of cases of stillbirth. Even in cases where no cause of death is found, post-mortem examination can exclude many important causes of pregnancy loss, some of which are known to be recurrent. Unless carried out under instruction from HM Coroner, all post-mortems are considered hospital post-mortems or consented post-mortems. These are most often carried out at the request of the family. However, sometimes a clinician looking after a patient may be keen for a post-mortem examination to take place, and very rarely even the patient themselves may request that a post-mortem is carried out after their death. Hospital post-mortems require written consent from the next of kin, and there are standard forms available from the HTA or SANS. At CUH, there is a local consent form package which is available on Merlin. The consent form covers the extent of the examination to be performed, but also other issues such as what happens to the tissues after PM and whether the parents consent for research or teaching. Consent in the perinatal setting is most often given by the mother or birthing person. In very exceptional circumstances, consent may be given by their partner. However, this is very unusual and would require a discussion with both the mortuary team and trust legal services. In law, fetal tissue is considered to belong to the mother or birthing person, and it is treated as such. If a baby is born alive, regardless of their gestational age, they are considered a person in their own right. As such, consent can be given either by the mother, birthing person, or the maternal partner if they are married, in a civil partnership, or with declared parental responsibility. So moving on to discuss the different types of post-mortem examination that are available. External examination is a non-invasive examination of a baby, which includes weights, measurements, assessment for any features of dysmorphism or structural abnormalities. The choanal and ear canals are gently probed. We look in the mouth, and it's rather similar to a newborn baby check. No incisions are made on the baby. It may also include x-rays if appropriate and clinical photos are taken. If a placenta is provided, this will be examined, and cytogenetic testing of placental material will be performed if appropriate. The next type of examination is the limited post-mortem. This is a more invasive examination, but the person giving consent can stipulate what we can or cannot do during the examination. The most common limitation is that the brain is not removed. This kind of post-mortem can be helpful if abnormalities in specific organ systems have been identified antenatally. However, by limiting the examination, it may limit the usefulness of the examination overall. If in doubt, please discuss with the paediatric pathology team before sending the baby to the mortuary. Depending on the limits of examination, we may still be able to perform some ancillary ancillary testing such as microbiology or virology testing. The final category is the full postmortem, which is the most comprehensive examination of the baby, including examination of all of the internal organs. This includes the brain and can also include more specialised techniques such as long bone removal in cases of skeletal dysplasia or removal of the spinal cord. It may include microscopic assessment of the tissues, virology and microbiology testing, and similar to the other types of examination, the placenta will be examined and cytogenetic testing undertaken if appropriate. All types of examination include fetal X-rays if deemed appropriate in that setting. These are plain film X-rays, usually AP and lateral views, and these allow for assessment of bone development and demonstrate extraskeletal abnormalities. Sampling of fetal tissues for histology may be undertaken in limited and full postmortems. The photo here shows the amount of tissue that was taken from a full postmortem of a term stillborn baby. For reference, the grey blocks are around the size of a postage stamp, so you can see that the material sampled is really quite small. These blocks go on to be fixed in formalin and are processed with glass slides produced. Organ retention is something which is not uncommonly asked about by families, but is very, very rarely required. To allow for examination of the brain, and occasionally the organs if the tissues are difficult to handle, they are placed into formalin, which firms them up and allows for them to be better examined. This may be for a few hours only, up to a few days for a brain from a stillborn baby. There is often very minimal delay in releasing the baby in these settings, and in exceptionally rare circumstances, for example, an operated congenital heart abnormality, an entire organ may be referred to an outside subspecialist for examination. This is rare and requires explicit written consent from the family and should have been discussed by the clinicians, family and pathologist prior to the post-mortem. Placental examination is performed in all cases, whether external, limited or full, if a placenta is submitted with the baby. We ask that these are kept unfixed and are sent with the baby when they are transferred to the mortuary. Placental cytogenetics and microbiology samples should be taken by the clinical team before sending the placenta to us. Placental genetics only requires a small sample to be taken. Please avoid detaching the umbilical cord when sampling, as this can cause issues when assessing the placenta later. After the post-mortem, there is a turnaround time of approximately 6 weeks for the issuing of a full report. However, these may be delayed if a case requires waiting for a full cytogenetics report, which often takes longer. In the meantime, the baby can be released to the family or funeral directors as soon as the examination is finished. In cases where there is a religious requirement for rapid burial, we can facilitate this, however, we must be made aware in advance. Following reconstruction, the baby can be viewed by the parents, they can hold their baby, and the post-mortem incisions are typically done in a way which means they should be covered by a standard baby grown hat. Should a family wish to visit their baby before or after the PM has taken place, we have a chapel within the mortuary which they can book. If you have any queries about post-mortems, please contact the Paediatric mortuary on the number below. Pathologists can be contacted via the mortuary or via Epic. There's a 24-hour on-call mortuary service, and we are happy to facilitate visits to the mortuary by arrangement, including the viewing of a post-mortem.